I'm now delighted to introduce Peter, who's one of your own, a cardiologist, is going to talk to you about some of the QI work that's relevant to cardiology specifically. Thank you, Peter. Do you want to take this?
So thank you very much, Mike. My name is Peter Wilkinson. I am fairly long in the tooth, as they say, cardiologist. I work at St Ashford and St Peter's Hospitals, which is a moderate-sized district hospital on the outskirts of London, Junction 11 on the M25, if you want to know in detail. And like many DGHs, we have developed our services, so we offer primary PCI and we offer complex devices as well. And over the years, of course, we've built up our service. I think what challenged me when I was asked to talk about this was what we are doing with the data that you have been told is available. And I was somewhat disappointed, I have to say, with our use of the data, particularly the NICOR data. And we have an extremely good data collection person, Peter Edwards, in our hospital. And I had to go and find him recently to find out where he'd moved to. I'd lost touch with him. So that just tells you that we had a really dedicated person in the hospital who spent a lot of time putting very good data into NICOR, and we were not using that data as we should do. So I'm just going to give you a few personal reflections before we break for lunch. One is clearly that audit is nothing new. I was thinking about Florence Nightingale as I came up on the train this morning, and she was an amazing person, wasn't she, who introduced better care into the Crimean War for the soldiers fighting there. And interestingly, and very topical, she was very keen on hand washing. And that led to a significant improvement. We have to relearn these things, don't we, as we go through life. In addition, audit is nothing new in cardiology. 26 years ago, I was on a working group, which was a joint audit committee of the British Cardiac Society, as it was then known, and the Royal College of Physicians, which set out certain standards for the treatment of acute infarction. I'm just going to quote a couple of points from the article in the journal of the college. One is, recording data for audit purposes is only worthwhile if they will actually be useful for recording and modifying practice. You've heard that message already today, but it is so true, isn't it? We spend a lot of time collecting data, and we don't always use it effectively to create change. Even then, we were talking about standards. For example, in secondary care, the proportion of patients having an ECG within 15 minutes of arrival, those were the old days, weren't they? The number receiving thrombolytic therapy within 30 minutes of arrival, and then the number receiving thrombolytic therapy within 90 minutes after the onset of major symptoms. So 26 years ago, we were already setting standards out, but we didn't have the technology, the IT, and the amazing database that NICOR has collected over the years that we could use effectively in creating change. So what's quality about? Some fairly obvious statements here. It's got to be safe, effective, patient-centered, timely. We talked about primary PCI already in some depth today, efficient and equitable, and those are statements from the US Institute of Medicine. Equity in the US may be somewhat debatable, and we are very fortunate in our health service in having, in general, an equitable system. Here's a quote I'm going to allow you to read from Professor Mary Dixon-Woods, which she gave a couple of years ago. So again, I guess this rings a few bells, doesn't it? Huge amounts of data coming in. What are we doing with it? Are we just feeding it up the food chain to CCGs, to NHS improvement and whatever? Or are we really using this data to create change on the ground? And what about the difference between audit and QI? Because Mike and Mark have talked about these terms, and I'm just going to show you the official, if you like, statement from the College of Physicians, Dr. Jane Yude. Again, I'll give you a moment to read that. So what is the difference? Well, to me, the QI story is all about a more effective mechanism, and Mike and Gabriella are going to talk about this in more depth this afternoon, to create the change that we want to make from the data we've got. And audit, although it's a useful term, has a slightly passive sense to it to me, and QI does give us more impressive tools to create that change. And on the same theme, this is a letter to the BMJ. So again, is it just a name? Are we just renaming something? Are we really making a change in the way we do things? And I think we are potentially making a change in the way we do things by adopting this methodology. So Mike has already talked about these, and I'm going to skip over these for in terms of time. But where are we getting the ideas from? Well, you've already heard a lot about NICOR today. I'm going just to talk about one aspect of this, which is available on the NICOR site, about radial angiography. So I'm no longer let near an angio lab. You'll be pleased to hear. They kind of lock the doors when they see me coming. But many years ago, radial artery angiography started to come in. And I went to one of the first courses in Crewe. And Crewe developed a very good program, a day case course. And I went back and I thought, right, I better be starting to do this. And we have started to do it, but as Mark knows, if you look at that graph, it's rather slow. It's improved, but it's desperately slow in improving. Could I have gone back, and I could have gone back to my hospital and said, we're all going to do this. We need to understand why we're not doing it, because the safety of radial is clearly better than the femoral approach. Could I have adopted a QI methodology then to explain why, to talk about the issues that might stand in the way of making a change, and actually produce change much more quickly than we have done? Obviously, we can as well learn from personal observations that we all have, complaints again from our patients. Are we really learning? Again, I'm reflecting on the radial approach. The problems with, say, retroperitoneal bleeding from the femoral approach are well known. So if we are starting to have those, or had those, hopefully in the past, are we taking that incident and saying, well, we could be doing things better? Meetings and colleagues, of course, like this, we're sharing information here. We have national meetings which we go to. We learn from other people. And I thought that comment that was made about sharing good practice is really important, and I think that's something that we could do more of. And Mike mentioned that possibility of taking hospitals which have created that change and perhaps partnering them up, buddying them up with units which are struggling. Can we learn from each other in a more effective way? Patients already alluded to. And lastly, that sense of we don't respond very well, do we, to being told what to do. But there are occasions when we perhaps need a sense of direction. But in general, as professionals, we like to create our own ideas and create our own change. So what are the barriers to creating change? One is convincing people there is a problem. This is where the data comes in, data-driven. I am old enough to have worked in Bristol many years before the problems with cardiac surgery appeared there. And that was one of the challenges that came out from Bristol, as we all know. which kick-started the much more open visibility of data for both cardiac surgeons and now, as we can see, from cardiologists as well, and led to a change and led to an improvement. So using this data to say to our colleagues back at the ranch, look at this. We are not just average, but we want to improve, or we are below average and we really must improve. Convincing people the chosen solution is the right one. Again, that comes back a little bit to the radial approach, having the data to say, this is what we should be doing, this is why. We talked about a little bit about excess ambitions. We can't all reach 95% and above. That's unrealistic. Carrots and sticks, sustainability, and so on. So I'm going to move quickly onto resources. And the College of Physicians has a QI hub in Liverpool. Its leader is John Dean, who's a physician in East Lancashire Foundation Trust. And John is a passionate advocate of quality improvement and has been to the IHI in Boston for a considerable length of time. So a real expert on QI. And the college has a program, some collaborative work, which I'll come to briefly in a moment. The IHI as well is an internationally known body which has some online courses which can be taken, or more extensive courses if you want to get really expert at it. The Health Foundation, I'm mentoring a couple of sites in the UK for the Health Foundation, so that is a useful resource as well, and they're particularly keen on the involvement of patients in moving quality forward. Dear NHS Improvement, of course, has a lot of information as well, as has the Healthcare Quality Improvement. I'm going to mention briefly the link between the College of Physicians and the Academy of Engineers. So that's a useful collaboration which John Dean has created. The engineers have a particular methodology in quality improvement. They don't want their bridges to fall down, so they're pretty good at making sure they don't. And can we link in with other professions to see what we can learn from them? So there is quite a hefty document online, which you could look at if you're interested, looking at that collaboration between clinicians and the engineers. A local professor, Tom Downs, an absolute expert in quality improvement in Sheffield, runs a microsystem coaching academy and has spread that particularly in the north. An absolutely strong advocate of quality improvement. And lastly, the Get It Right First Time. I've mentioned the collaborative with the College of Physicians, and here is a collaborative supporting teams to improve care for patients with atrial fibrillation, a 12-month QI course. So I think that's just about closing for people who want to participate in it, but here's the college reaching out to people and say, we can give you for a bit of money, it's true, some expert advice in creating change. So next steps, clearly we talked about what do you want to improve. You've got the data from various sources, from NICOR and so on. Define your question. The engineers really take a long time to say what really do you need to do, what do you want to do. Mike has already talked about composing the team. How you're going to measure it, what techniques you're going to use, start collecting the data, make the change. And if you are successful, spread. Lastly, before the next slide, which is time for lunch, I'm just going to quote from this paper which came out this week in the British Medical Journal. It's called Revitalizing Audit and Feedback to Improve Patient Care. I think it's really appropriate to this meeting, and it's particularly appropriate because the lead author is Professor Robbie Foy, Professor of Primary Care at guess what, Leeds Institute of Health Services, and one of the other authors is Sarah Alderson, Clinical Lecturer in Primary Care. So an excellent article, and just a couple of quotes, Mike. One is, the success of national audit programs depends on local arrangements that promote action as well as measurement. It's a point I made initially. Secondly, without functioning local networks and systems, national audit programs can become echo chambers, where good intentions and blame for limited progress reverberate. Audit and feedback will flounder if local quality improvement is based on repeated, unconnected, and inappropriately delegated projects conducted in isolation from mainstream pursuits, and if any learning is dissipated in collective amnesia. Strong comments, but it's so true, isn't it? We have this great resource with NICOR and other databases. Let's use them effectively, using the techniques which are going to be talked about this afternoon to improve the quality of care we give to our patients. Thank you.